And all this while, chemotherapy and radiation has been the main treatment for cancer in general and also blood cancers.
But now with the new CAR T cell, we are using that treatment to actually save some of our patients as well. So the treatment has progressed or developed from chemotherapy alone and with additional immunotherapy, and also we are using more of targeted treatment, and we're also changing a little bit how we treat patients who need transplant using CAR T cell.
Can I ask you, why is it so expensive?
Yeah.
Hello, I'm Dr. Tony Setiobudi. Welcome to this podcast. Blood cancers like leukemia and lymphoma affect millions of people worldwide. For years, doctors have used chemotherapy and radiation to treat them. These treatments can help, but they also damage healthy cells. That's why patients get side effects like hair loss, nausea, and vomiting. But there is a breakthrough. Scientists are using the body's own immune system to fight cancer. It is called CAR T-cell therapy. The treatment is changing how we fight cancer today. Joining me today, we have Dr. Yuh Shan, a hematologist at Parkway Cancer Center. Hi, Dr. Lee.
Hi, Dr. Tony.
How are you today?
Good.
Cancer is one of the biggest challenges in our health today. So, what is actually cancer in the simplest term?
Cancer in the simplest term is abnormal cell that is growing out of control and affecting the normal function of our organs, including the normal function of marrow.
Of course, not just blood cells, but we have cancers affecting other organs as well. Right?
Yes. For example, the lung cancer can affect the organ, the lung function, and the liver cancer affect the liver function.
And if we talk about CAR T-cell therapy, this is very specific for blood cancer. Is that correct?
Correct.
Can you tell us briefly how CAR T-cell therapy help in blood cancers?
Okay, CAR T-cell is a new type of cell therapy which is changing the landscape of treatment for blood cancer. So in this CAR T-cell treatment, we are using patient's own immune system to actually attack the cancer cell. So we will collect the patient's own T-cell, which is an immune cell. We are going to reprogram them, grow it back, and then infuse back to patient to hunt down the cancer cell of interest.
Okay. So I heard also that actually cancer can trick the body, can hide somewhere and to evade our immune system.
Yes.
How do they do that?
Yeah, so that's the issue with the cancer. They are a little bit tricky. For example, they can actually reduce the expression of antigen to avoid the immune system from recognizing them. They also can hide by using surrounding tissue to evade the immune system. And thirdly, of course, they can also use all this cell-to-cell interaction to make the immune cell go into sleeping state so they don't attack the cancer cell. These are the few examples. Of course, there are more examples of how cancer actually avoid immune system.
Naturally, our body immune system can attack the cancers or cancer cells, but because they can hide somehow like with the mechanism that you just mentioned, the body immune system cannot attack them.
So if in normal circumstances, our body will be able to recognize some of the antigen on the surface of the tumor cell or the cancer cell, or some of the tumor antigen being released by the cancer cell. So that will actually teach the immune cell to be able to recognize all this cancerous cell. And so once all this immune system being educated to recognize the tumor cell, they will hunt down the tumor cell and kill it.
Okay, if you have any questions or comment, please write it down in the comments. Leukemia and lymphoma are the two most common blood cancers. Right? But what exactly are these cancers?
Yeah.
Leukemia and lymphoma.
Yeah, so in simple terms, right, leukemia is all the blood cancer that you can find circulating in the blood, while lymphoma is all the blood cancer. Usually they present in the lymph nodes, that like enlarged lymph nodes that you can actually biopsy and find all these blood cancer cells in the lymph nodes. That's called lymphoma. So usually the leukemia, they are more aggressive, they're more immature, and more life-threatening. While in lymphoma, usually the cells are a little bit more matured and usually can be treated, if you treat well, the outcome is actually better.
Okay, how do these cancers cause danger in our body or can kill as well, right?
Yes.
How do they do that?
Yeah. So when your patient have blood cancer or leukemia or lymphoma, usually the immune system will be low. As I said, cancer actually impact the normal organ function. So the bone marrow function, for example, the production of hemoglobin that will be affected. Patient become anemic, tired. The platelet also be affected. Patient will present with a low thrombocyte count, and then of course the immune system will be impaired by this a high amount of blood cancer cell, leading to what we call that the multi-organ failures. For example, they can have a persistent fever. They can have all this thing called tumor lysis, causing all the organ to fail eventually. And most of the time, if you don't treat the blood cancer well, they'll pass away due to multi-organ failure and infection.
And all this while, chemotherapy and radiation has been the main treatment for cancer in general and also blood cancers.
Yeah, so the the field of hematology and oncology has gone through a long path of research and improvement. So previously, yes, we used chemotherapy, but now we add on immunotherapy in the backbone of chemotherapy, and we have a better result. We are also using some targeted treatment now, which is chemotherapy free, and of course, the same thing when we talk about this cell therapy. Usually, last time we used to use autologous or allogeneic stem cell transplant, but now with the new CAR T cell, we are using that treatment to actually save some of our patients as well. So the treatment has progressed or developed from chemotherapy alone, and with additional immunotherapy, and also we are using more of targeted treatment, and we're also changing a little bit how we treat patients who need transplant using CAR T cell.
Tell us briefly about immunotherapy.
Okay, immunotherapy basically is using antibody to actually attract our immune system to go to the site of interest and actually kill the tumor directly.
What about targeted therapy? What's targeted therapy?
Okay. Targeted therapy is actually a therapy that actually developed by using or targeting the Achilles tendon of the cell tumor growth. So they know that some certain tumor, they are addicted to certain tumor pathway, development pathway. So all these are using things like inhibitors. For example, the one that being developed many years ago for the chronic myeloid leukemia.
Now let's talk about the side effect. What are the usual side effects of chemotherapy?
Again, we always have this impression chemotherapy will cause a lot of side effects. Give already, then the patient will suffer. But we also gone through a long way of development. We have a better supportive treatment now. All this nauseous vomiting, actually we even have medication that reduce vomiting for 1 week. You don't have all this nauseous vomiting anymore. Reduce appetite, yes, we still have a little bit of reduction in appetite. Hair loss, unfortunately, we still are trying to find the magic to reduce hair loss. So these are temporary side effects. But the majority of patients will experience some of these minor side effects, hair loss, nausea, vomiting a little bit, and sometimes they got altered taste sensation. Some patients may have a little bit of skin rash as well. But generally, these are actually quite tolerable. And we are not talking about, the past that the chemotherapy make patients suffer so much. Generally, patient can tolerate the chemotherapy well now with supportive treatment.
As a hematologist, do you also use radiation therapy?
We do recommend radiotherapy for certain type of cancer. For example, I just had a patient with a stage 1 lymphoma, which I'm going to consolidate with the radiotherapy after completion of immunochemotherapy.
Okay. The side effect of radiation?
So the side effects of radiation, it depends on the site that you want to radiate. Usually those site that you want to radiate, which is near to our heart or breast, usually these are the area we are trying to avoid because the long term, they may cause some increase in arteriosclerosis and hence increase the risk of getting some heart disease. And otherwise, if the area where there's no organ nearby the tumor, actually the side effect is quite manageable. Some of the common side effects, the skin pigmentation. Sometimes they can cause a little bit of side effects, right? Sore throat, Those are again minimal and actually quite tolerable.
So in general, if people got leukemia, lymphoma, multiple myeloma, how long is the duration of treatment?
Oh, the duration of treatment really depends on what type of blood cancer you have. In general, for lymphoma, first line, usually we get about 4 to 6 cycles. We seldom give 8 cycles like what Western do, because I think 6 cycles is usually what we can achieve. And for myeloma, usually again, some of the treatment is 6 cycles, some of it is continuous. And for leukemia, it depends on the type of a leukemia and whether patients need to undergo bone marrow transplant. So those are variable.
Like one cycle, how long does it take?
Again, all these depends on the protocol or the regime that you're using.
Normally,
it range from 21 to 28 days.
What about bone marrow transplant?
So bone marrow transplant is I would say, is a process where actually we replace the patient's bone marrow with a healthier cell. And there are actually 2 types of bone marrow transplant. We call it autologous or allogeneic. So autologous, the idea of autologous stem cell transplant is to give a stronger chemotherapy to kill off residual blood cancer cell, and then infuse back the stem cell to speed up the recovery of the bone marrow. On the other hand, the allogeneic stem cell transplant is by using healthier bone marrow donor stem cell to actually replace the unhealthy bone marrow of the patient. And we also hope that when the immune cell of the donor grow up, they can actually be the policeman or to kill off whatever residual tumor cell or blood cancer cell the patient had.
And the process normally it takes how long?
Autologous stem cell transplant is actually about 3 to 4 weeks. Usually got some chemo, then stem cell infusion. Allogeneic stem cell transplant, I say, is a process. You do give a conditioning regime. Then after that, kill off the cell already, the donor stem cell come in, and then after you wait for the counts to recover. Usually it takes about 14 to 21 days for the stem cell to recover.
Okay.
We call engraftment. Yeah.
So this is interesting. We have covered leukemia, lymphoma, the treatments like chemotherapy, radiation, immunotherapy, targeted therapy with the side effect. And so if you have any questions and comments, please write it down in the comments. And don't forget to like and subscribe. Now let's go deeper into the CAR T-cell therapy itself. So CAR T-cell, we have CAR, we have T-cell. What is T-cells? What is CAR?
Okay. Yeah, so CAR T-cell, CAR or CRL means a chimeric antigen receptor T-cell. So that's why you call CAR T-cell. So the name actually implies that we are using patient's own T-cell, but this will actually genetically be modified or reprogrammed so that they can actually express this chimeric antigen receptor on the surface of the T-cell. So this receptor is important because these are the receptor that will hunt down the tumor cell specifically and kill it. So that's why CAR T-cell is
Right. Can you explain to the lay people about T-cells? What is T-cells?
Okay. So T-cell is a part of our immune system. When we talk about T-cell, actually we are talking about lymphocyte. And when we look at lymphocyte is a type of immune cell that actually help us to fight viruses in general term. But they also actually play a key role in fighting or killing off all this cancerous cell. So we know
Naturally,
yes.
What is the difference between T-cells, just normal T-cells, and CAR T-cells after you modify?
Okay. In a way, T-cell is the normal naturally T-cell is more like normal soldier. CAR T-cell is a supercharged T-cell or supercharged soldier that can actually hunt down the tumor specifically and kill it off more effectively as compared to normal T-cell.
Okay, in the process of making it CAR T-cells, what actually is done to
Oh,
the normal T cells?
Yeah. So usually we'll collect the patient's own T cell. Yeah, and this will send to the lab under stringent condition. This T cell will be reprogrammed to be able to express this CAR, which is chimeric antigen receptor. So this T cell, how do we reprogram that? Actually, is genetically modify them. So the T cell can actually express this CAR. And once we can reprogram them, we'll grow them in millions. We will infuse back all this CAR T cell to the patient. And once in the blood, all these CAR T cell, because they are reprogrammed, they can actually recognize and hunt down all this cancerous cell easily and kill it off all this cancer cell that we want.
Why is it only applicable for blood cancers?
Yeah.
Solid tumor.
Yeah. So far the research is very specific, and we have been very successful in blood cancer, because blood cancer in a way is very liquid. So there's no barrier. Once you infuse, they can hunt down the tumors, the cancer cell. Of course, it is also very effective in lymphoma and myeloma. So lymphoma, although is in the lymph nodes, but the tumor, everything is more homogeneous in the expression of the antigen, right? So it's easier for them to kill off all this blood cancer.
Can you explain the patient's journey? Patients who have blood cancer who is going for CAR T cell therapy.
So usually once the patient is being referred to us for CAR T cell treatment, we will actually assess the patient, and the first thing is we have to make sure the indication for CAR T cell is correct.
Yeah.
And we are not using CAR T cell for blood cancer for solid cancer, no. And we also that's why we need to make sure the indication is correct. We also need to make sure patient is fit enough to receive this CAR T cell treatment. So once all this being analyzed and being assessed, if they are fit, actually we'll start with collecting the T cell from patient first.
Yeah. Any age limit?
Interestingly, in the clinical trial, the age limit is 99 years old. So it is quite extensive, but we are very specific, because I think once patient reach certain age, the fitness is not so good. That's why we always encourage patient to maintain their fitness, and they need treatment. At least they are still eligible for certain type of treatment, including CAR T cell therapy.
What are the indications for CAR T cell therapy?
In Singapore, so the CAR T cell is very specific. We follow the international guidelines. Okay. The CAR T cell available in Singapore is for relapsed or refractory B diffuse large B cell lymphoma or aggressive lymphoma, and for leukemia, it's very specific for B acute lymphoblastic leukemia, and for multiple myeloma, these are the one for relapsed refractory multiple myeloma. So very specific. We are using it at second line and third line and beyond.
Not first line.
Not first line, although there are ongoing research trying to challenge the immunochemotherapy versus CAR T cell, but these are ongoing, and I think we should not jump our gun and use that as a first line.
So after got the right indication, patient is fit, then what?
Yeah, so once we're fit, right, then we'll actually schedule the patient to be admitted to actually collect the T cell. So once the T cell has been collected, the T cell will be sent to the manufacturing facilities to manufacture the T cell. While waiting for this CAR T cell being produced, right? So it takes about 2 to 3 weeks to be able to get the product back. And patient will have what you call bridging treatment, or something to control the disease while waiting for the production of this CAR T cell. So this ranges from using treatment such as radiotherapy again, and also some gentle chemotherapy. The main thing about this is want to give something to control the disease, but not too intensive that patient get complication and not be able to receive the CAR T cell that being produced later.
Okay, how do you collect the T cells?
So T cell is collected using this process called leukapheresis or apheresis. Basically, it's almost like dialysis patient. We actually take the blood in the machine. Machine actually separate the blood into 3 layers, like the red cell, the plasma, and the white cell. Okay. They'll take away the white cell and return the rest of the blood into for the patient. So we only very specifically collect the white cell, and this white cell, after that, we send to manufacturing. They will actually tease out which are the T cell that they want, and actually throw away the rest. So this is very specific and what do you call that? using a very stringent environment, using high cutting edge technology.
Okay, so then after the T cell is separated, then re-engineered to make it CAR T cells,
Correct.
and then culture, grew it,
Expand it.
make it a lot,
Make it 10 million, billions.
then you give it back to the patient.
Yeah, then we
And that
give it
process
patient.
can take, you say 3-4 weeks.
2 to 3 weeks.
2 to 3 weeks.
From needle to needle time, about 3 weeks like that. Means needle to needle from the time you collect until the time you infuse back. It can be as short as 3 weeks. Sometimes it extends a little bit up to 4 weeks.
So then after you get the CAR T cells ready, how do you put it back in the patient?
So once we are always in communication with the manufacturing facilities, see what's the process, which stage they are is manufacturing. In fact, after they are manufacturing, they will tell you whether it's successful or not. And after that, have to go through the quality control, make sure all these are free of viruses and all this infection before they actually send back. We will roughly know when we are getting back the product. And once we know, right, then we will prepare the patient. How do we prepare the patient is we need to give a little bit of chemotherapy, gentle chemotherapy, to kill off residual lymphocyte or T cell in the patients. So once we do that, then after that, the CAR T cell will come in. So that actually create a space for the CAR T cell to expand and actually to kill off the tumor cell.
This is very fascinating. A new technology, a breakthrough that can change the treatment of blood cancers. If you have any friends or family with blood cancers, you can share this podcast to them. I hope this is useful. CAR T cell therapy is an exciting advancement in cancer treatment, but it is not without challenges. So what kind of side effects can occur in CAR T cell therapy?
Yeah, as I mentioned before, even all this targeted treatment and immunotherapy, they have their own unique side effects. So similarly, we also have some side effects associated specifically with the CAR T cell treatment. So one of the more common side effects is what we call cytokine release syndrome. In a way, or in the layman term, it's almost like a patient having very bad fever. So patient actually present with high fever, and sometimes they may have all this, because high fever, sometimes infection, you get a little bit of low blood pressure. All these are the things that can happen. So it's what we call cytokine release syndrome. Of course, with research, we recognize which are the biochemical in our body that actually cause this cytokine release syndrome. It's what we call interleukin-6, IL-6. So basically what happens is CAR T cell kill off all this tumor cell, the release of chemical to kill it off or from all this cell, and these are the chemical that actually cause the fever. And so we give inhibitor to this IL-6, and actually we can actually control this syndrome quite well. So the key to this is actually early recognition, and actually we have a protocol to actually monitor all these CAR T cell side effects. Another CAR T cell side effects is what we call ICANS, or immune effector cell associated neurotoxicity. As the word implies, neurotoxicity means something with our intellectual or cognitive. Sometimes patients may present with all this tremor, a little bit drowsy, a little bit confused, and sometimes they may, when they speak, when they write, their handwriting, they may change a little bit as well, become more tremorous. So these are the things we monitor when patients receive this CAR T cell treatment. And if necessary, we'll give the necessary treatment, for example, steroid for ICANS and then IL-6 inhibitors for this CRS. These are the unique unique side effects with CAR T cell. Of course, in the long term, we also recognize that sometimes CAR T cell cause the white cell count to be a little bit low. So this is well recognized. And usually we give a supportive treatment like booster jab to actually help with these side effects.
Is cytokine release syndrome dangerous?
Yeah. So cytokine release syndrome has many grading from grade 1 up to grade 4. So grade 4 is like patient having very bad infection. The BP can be low, have difficulty in breathing. And these are the things that actually sometimes patient may need intensive care, unit support to actually help them with this syndrome.
Is it similar to severe inflammatory response syndrome?
Yes, I mean, we call SIRS, but actually it's something similar. But actually, we recognize that this is actually due to interleukin 6, or some interleukin like interleukin 2. So these are the ones that's why you monitor early. So once the patient have a little bit of fever or those things, then when they start to have grade 1, then you want to start to early intervene. Then actually to leave the patient to develop grade 3 or grade 4. So early recognition and monitoring is important in these kind of symptoms.
What is the danger in grade 4?
Grade 4 is almost like very bad sepsis. You'll be intubated, you'll be in ICU care, and may need all this blood pressure supportive treatment, and you may even need mechanical ventilation to help the patient.
Okay, so there are ways to prevent it from grade 1 to grade 4. If you detect it early and intervene early.
Correct. It's almost not prevent. It's a way for us to actually stop the process, prevent it from getting worse. Of course, there are ways to prevent it from happening as well. So we also know that this cytokine release syndrome can be associated with a tumor load. So it means the bigger the tumor, or bigger the lymphoma or leukemia, actually the risk of this CRS is bigger. So the idea now is how to make the tumor a bit smaller. When patient receive CAR T cell, you can get a better control.
You do that?
Yeah, which is why all this radiotherapy may help, or some bridging treatment that actually can reduce the tumor size better, can help with the treatment.
This applicable for leukemia as well. The size, how do you judge the size of leukemia?
So that's why the size or tumor bulk is actually, if you look at the size, more lymphoma.
Lymphoma.
Yeah, but if you look at in terms of leukemia, so you need to get it under a certain degree of control before you actually give it to reduce the risk of cytokine release syndrome.
Normally, lymphoma is patient present with lump in the lymph nodes.
Yes, usually in lymphoma, patient will present with the enlarged lymph nodes or enlarged spleen. And this is how actually we use radiotherapy to actually kill off some of the cell before we actually do the CAR T cell treatment.
Is it 1 or 2 lymph nodes or many lymph nodes?
Yeah, so in the patients who are preparing for CAR T cell, it may have 1 lymph nodes that's very big, that's easy to target. Sometimes they may have multiple lymph nodes. So how to target? We may give some systemic treatment, or we actually target the largest tumor so that actually reduce that size. And when patient go in for treatment, they will actually reduce the risk of cytokine release syndrome or ICANS.
One last question. I heard CAR T cell therapy is very expensive. You don't need to tell me the figure, but can I ask you, why is it so expensive?
Yeah. CAR T cell treatment, I mean, if you say the cost per se as compared to other treatment like immunochemotherapy, it is a little bit more expensive. One of the reasons is because once you collect, right, the T cell will sit aeroplane all the way to fly to overseas to actually manufacturing site. It's something like very urgently. So because the cell will die if you delay it, so you need to send it urgently. The cost of transport, and then the stringent lab that produce a CAR T cell need to go through this very stringent assessment to get this facility being set up, because we don't want contamination. So the quality control is very tight. And of course, something being new, all this thing, of course, there are some risk and some hike in the prices. But over the years, I mean, talking to the manufacturer, and then we managed to cut down the price of this CAR T cell. But if you're looking at the cost as a whole perspective, right? The good thing about this CAR T cell, if you compare to conventional treatment like chemotherapy or autologous, it's very specific with a higher response rate. Let's say, you try to use chemotherapy, it's a chemo, and then followed by transplant. And if you add up all this cost together, it's probably still a little bit cheaper, but not very far from CAR T cell. And the time you need to actually go through this try and error actually is longer. Yeah. So yes, CAR Ts are a little bit more expensive if you look at the cost alone. But if you look at the whole general perspective and the time needed to undergo the treatment, and I think it is a little bit expensive, but I think it's manageable in a way.
Yep. Okay. Now we come to the last segment, fact or myth about cancer. So I'm going to read up some statements, and you can say it is fact or myth, or half fact, half myth, with short explanation.
Okay.
Are you ready?
Okay.
Number 1, cancer is inherited.
Yes and no.
Yeah, okay. So,
Yeah, certain cancer like solid cancer, they maybe have some specific genetic mutation that may be inherited, but not all the cancer lah.
yeah. So majority are not
A majority
inherited,
are not. Yes.
not genetic. Okay. Number 2, chemotherapy only targets cancer cells.
No, because chemotherapy is not very specific. They do cause some collateral damage to our body, but usually these are being minimized by using other methods to reduce elevate the side effects.
Okay. Number 3, CAR T cell therapy can cure all cancers.
Myth. No, it's very specific for certain type of blood cancer, and of course it gives the patient best chance, but we do see high cure rate, but not all patients being cured. That's a fact.
Okay. Number 4, a strong immune system can sometimes fight cancer naturally.
In medical, we are in the middle path. Sometimes too weak, not good. The infection come in. Sometimes too strong, they start to not only attack tumor cell, they attack your own body. So I guess in the middle is better. Not too strong, reasonable. Healthy lifestyle, keep the immune cell reasonably strong, not too strong.
So is there any case where cancer cells disappear naturally because of good immune system?
Well, of course, in medical, it's always not like 1 and 0. We do see some of the low grade cancer. If we monitor, some of it may resolve. May happen, but of course it's a minority lah.
Yeah. Okay. Number 5, only old people get cancer.
No, we do see cancer in younger population as well.
So, okay. Number 6, side effects from cancer treatment means it doesn't work.
Not really. Sometimes we do. There's most of the side effects are expected. Of course, sometimes we do see some out of expectation kind of or rare side effects. But sometimes all these side effects is a reflection that actually the treatment is working very well until you get all these side effects.
Okay. Number 7, CAR T cell therapy is available to everyone with blood cancer.
We have to be very specific, say no, because it is available, but only in certain conditions that we offer this type of treatment, CAR T cell treatment.
Must be the right indication and right indication selection. Yeah. Okay. Number 8, eating sugar directly feeds cancer cells.
No. So this is a thing that you always say that patient got the cancer, cannot eat rice, cannot drink anything with sugar is wrong, because cancer, regardless of your source of energy, they will still take up energy from patient self and will actually not directly feed on cancer.
Okay, so eating sugar, patient with cancer is okay.
So if it is so easy, right, then we should tag the sugar with some radioactive thing. Once cancer eat it, then they'll die. Then that will be an easiest solution for cancer, right?
Maybe you can develop that treatment. Number 9, cancer is contagious.
No.
Okay, cancer is not infectious disease.
Not
it is
contagious.
It is
not. But maybe you touch a patient with cancer, we will not get cancer the next day. It is not.
Number 10, cancer treatments are improving every year and survival rates are higher than before.
Yes, correct. Yeah, that's how we're trying to break the next barrier so we can improve on the patient's survival and also the quality of life. Not only survival, we need to have a good quality of life as well.
With new technology like immunotherapy, targeted therapy, and CAR T cell therapy.
Correct.
That was such an insightful discussion we have today about blood cancer and about CAR T cell therapy. Thank you so much, Dr. Yuh Shan, for sharing with us. Before we wrap up, do you have any short take-home message for our listeners?
CAR T cell therapy is the latest technology we have to treat certain type of blood cancer. For example, aggressive B lymphoma, aggressive B lymphoblastic leukemia, and also relapsed refractory multiple myeloma. In this CAR T cell treatment, we use patients' own immune cell, we reprogram them, expand them, and infuse them to hunt down the blood cancer that we wanted.
Okay, that's all for you today. Thank you once again for joining us. And if you found this episode helpful, don't forget to like, subscribe,
and share.
stay healthy, and we will catch you again in the next episode of Doctor Say One Horh. Bye bye.
Bye.